Welcome to Session 4 of Rhythm Interventions Online 2023. The focus of this session is persistent AF, high-density mapping, and toggling PFA and radiofrequency catheter ablation based on substrate. For this session, I'd like to welcome our expert panelists, Dr. Musa Mansoor from Boston, Dr. Richard Schilling from London, and Dr. Atul Verma from Toronto. We would like to start the session with polls for you that our operators have put together, and we'll review the results towards the end of the session. So let's start with poll 1. How familiar are you with the PFA technology? Are you extremely familiar? Are you familiar? Just neutral or not at all familiar? And please go ahead and vote for these polls, and we'll come back. Let me go to poll 2 as well. Are you currently using PFA technology in your practice? Yes or no question. So at this point, without any delay, I'd like to meet our operators, Julian Chun and Bort Schmidt from CCB Marcus Krankenhaus, Frankfurt.
Yeah, super.
Hello, Julian, and hello.
Wonderful.
Bort.
Debbie, dear all, welcome back
welcome
to
back.
Frankfurt. And it's our pleasure to host our second case. And now we switch gears, not only with regards to technology and strategy, but also now I'm supposed to try to moving catheters, and Boris has been supporting me in the prep and also, of course, during the case. And first of all, again, we would like to introduce our full team. And may I have Janina and Mrs. Reda. She's our queen of the cath lab, and she's the princess of the cath lab. And we are very happy to have them with us. And we have, of course, also Dr. David Chark. And I don't know his specific role in that, but he will also and has been assisting us with the case. And the setting is the following. We have a lady, and Boris and David will briefly introduce later on in a second. But she is, and this is something which is, a little new also to us. She is in deep sedation, and we're using, as you know, the Affera system today. And but after some experience, we feel confident enough to use deep sedation instead of intubation and GA, even for this ablation modality. And we already started, I would say, puncturing maybe 30 minutes ago, and did some of the work because we know we have 1 hour to work with you guys, and happy to hand over the word to Boris, maybe.
Yeah, hi from my side too. It's exciting to be here, and as Julian said, I'm going to introduce the patient to you. It's a 68-year-old female with persistent atrial fibrillation. She came in this morning, and before we started mapping, we did an electrical cardioversion. Why did we do that? Because currently the system works a little faster when you map and acquire the voltage map. During sinus rhythm, it's more reliable in detecting low voltage areas, and that was the reason. In the history of the lady, she had undergone multiple electrical cardioversions, and aside from that, she's also suffering from arterial hypertension, so her CHA2DS2-VASc is 3. As you can see, Julian acquired the voltage map. Maybe you can turn it around a little bit. You see very familiar. The purple color is healthy, and the green and red colors are low voltage areas. You see the left-sided veins right here. You see the posterior wall. There's some substrate on the posterior wall and a lot of substrate on the anteroseptal part of the left atrium. The catheter is depicted nicely and now very close to the right upper pulmonary vein. We also are using a circular mapping catheter. Maybe you can show the fluoro in the image, and there's a circular mapping catheter sitting in the right superior vein. And as you can see from the electrograms, maybe if you want to show those, there is the baseline ECG in sinus tachycardia right now, and then there's the lasso catheter with in white and also the electrograms from the sphere 9 catheter below that. In green, you can see the coronary sinus catheter electrograms. Well, close to isolation, and maybe David can introduce the catheter to you a little bit.
Yeah, exactly. As you were already told before, the catheter is already inserted and was used to do some work. So I have a model catheter here to show you what it looks like and what it can do. If you can show it a little bit larger, it's a 9mm sphere lattice tap catheter, which has 9 microelectrodes and 1 central electrode. The microelectrodes have thermocouples, which can be used to detect the temperature, and this will be discussed later during the case, I'm sure. It is steerable bidirectional, as you can see here. I can bend it in both directions, and it is sort of compliant, so maybe this might be hard to see, but I can push it against my hand, and it's a little bit compliant. You maybe will see it better when I show you how it's introduced. So we can wrap this introducer, and it nicely folds into it. So this shows the compliance of the catheter, and you will see it live in the atrium soon, I think.
Yeah, super, David. Thanks for the introduction of the catheter, which is, of course, the super interesting part of it. Now we acquired the map. As you can see here, in CS pacing, it's a little faster with the acquisition of points. This is the reason why we did this. Then we already started to ablate. And you see maybe those green tablets. And maybe we switch back maybe to a monochromal picture, so color, so you may see it a little more better. My PA, go over to PA instead. Yeah, wonderful. And show us a little bit the roof. So we left still a gap along the roof. And this is, you came in the perfect moment. This is where we want to complete basically our circle. Just for the basic understanding, the green tablets indicate lesions deployed if we selected for electroporation for PFA. If we decide to go for RF, those lesions or those tags will be red. Okay, then there is a line, and depending on the the distance in between our lesions, the line should be as gray as you can see it here. All right, so we did, I would say, almost 70% of our circle, and now let's have back the electrograms a little bit, yes, bigger again, and you see the electrograms in pink. Those are the electrograms which you see here from the lasso, which is positioned in the right upper PV, and in white, the signals you see are those electrograms from the lattice catheter. And I think we should now move on and position our catheter again and the roof part, and I think this is a pretty nice already position here. There's multiple things to look at. First of all, we navigate our catheter without a steerable sheath. It's a regular SL1 sheath. Of course, one can also decide going for a steerable sheath. We use a non-steerable sheath. This is number one. Number two, you see already those white, big, large dots on the sphere 9 catheter, indicating pretty good contact in this position. And then you see next to it, L, which indicates the distance to the previous lesion, which should be 4 to 5, not exceeding 5 millimeters. And here, we basically meet pretty good our criteria. And I would connect from here on the next application.
Do we see the electrograms?
A little bigger electrograms, wonderful. Für die Regie einmal die Elektrogramme groß machen, bitte. Can we see the ECG? Yeah, wonderful. Okay, now the upper panel saying lasso, it's the spiral catheter, and below it's the sphere 9. And now we go for an ablation, 4 seconds. Okay, you see a couple of things. Number one, the vein is isolated. You see it here? It's nice, beautifully isolated, even though the circle was not completed. This is an important message. Number two, we also have seen this orange line indicating a very discrete temperature change and increase as a marker for a good and solid lesion exactly in that position. This is also a thing to look into, and therefore we are happy with this position, and we move along the roof a little bit more, again completing another lesion, connecting to the previous one, do a little rotation again, looking at my numbers, 2, 3 millimeters, nice white dots, and that looks pretty okay. Going a little back,
Can you
because
pace from the
you may have
spiral?
noticed a small... Oh, I'm sorry, there was a comment, yeah.
Yeah, Julian, I was just wondering whether you could pace from the spiral before you go on, just to show whether there's exit block there, whether you can capture the spiral.
Oh, yeah. Yeah, that's a good point. So can we please one time stimulate from the lasso and go and try to capture? So we are now pacing from the spiral catheter, and you can see we do not capture the atrium. And so therefore, we not only meet entrance, but also, yeah, exit block criteria. Good. Ario,
Julian,
hi.
Julian.
hi, Julian. It's Musa. I have. May I make a comment here and question?
Oh, absolutely, absolutely.
So,
Musa. Go ahead.
congratulations. It's a nice case, and you showed very nicely isolation, first pass isolation. Couple of things we do different when we use it when we use this catheter, and we used it in a good number of patients. First, we never used it with any other multi electrode catheter, because I believe that it's very easy to know when you have isolation or not. And it is, and frankly, we never had a case where you couldn't get isolation from the first pass. And number two, Boris mentioned at the beginning that you guys did the cardioversion at the beginning of the procedure. And this is something that we didn't do. And what was interesting is that I found out that in a large number of these patients, more than radio frequency energy, you get termination either into atypical flutter, which will be very beautiful to map with this catheter, or termination in sinus rhythm. And, I still don't know why you get more cardioversion with this during a more conversion with this rhythm rather than with this technology with RF, probably because you can get a much wider waka than what you do with RF. So I'm wondering if you have any comments on that.
Yeah, that's many good and very valid points, of course. And I think you're absolutely right, Musa, that we all are now slightly differently, but having very common and shared observations. And one of the aspects why we decided to actively still go for a second spiral catheter, because due to the organization of the PF energy, and we decided for the PVI or for PV only to use PF, there is, of course, an uncertainty about potential stunning effects and how much you can or need to ablate in order to see acute isolation. So this is something which at least we have been interested in, and this did drive us to better understand what was going on, and therefore decided to go for this. And we observed very, very often, and probably this is or would have been in alignment with your observation, but we have observed typically exactly what we had here, that without having completed the full circle or just leaving a tiny gap, we very often, after, I would say, 70% of the circle, we observed acute isolation. And therefore, we find it at least interesting because it may indicate a certain field and of stunning, area of stunning due to the catheter. And what was the second point? I forgot it. I'm sorry.
Second point about doing a
remember the second
cardioversion
point.
rather than ablating a normal rhythm because of the high rate of conversion to atypical flutter or sinus rhythm.
Musa, we do the following. Boris will answer this, and I do my last shot here, and then we go to the left side.
Musa, hi, first of all, but I like the observation that you share with us, and probably your explanation is also right, that you have such a large waka that you already include a lot of the rotors and drivers and whatever you want to call those into your lesion set when you do PVI. We have chosen to go for a different approach, so we were focusing number one on the PVI, first pass isolation, and also we are currently evaluating the catheter or the use of the catheter to perform an anteroseptal lesion in case we have anteroseptal substrate. And that's what actually another reason why we use the spiral mapping catheter. We, in the beginning of the procedure, we are measuring the conduction time to the left atrial appendage, determined or defined by beginning of the P wave to the local activation time in the left atrial appendage. And this is what we call time to LAA. And if that exceeds 100 milliseconds, we correlate that with the low voltage areas anteroseptally, and we draw a line, an ablation line from the mitral isthmus, from the mitral valve to the right superior pulmonary vein. And actually, in a very high proportion of patients, we also saw first pass block of this line that is very difficult to complete with regular tip catheters using RF energy.
I agree with all that, but all what you described to do, which is very interesting, can be done just with the sphere mapping because it can acquire the maps very quickly.
Yeah, you're right. The only thing is differential pacing is probably one aspect of this that two catheters can be useful.
But it's
Boris, can I
interesting,
ask
you mentioned you have a higher rate of expected termination in your cases in your clinical practice. Of course, it's speculation. Do you think it is because of larger lesions? Do you think we do stun larger areas which may contribute like a mini cardioversion? Or do you think this is due to the lesion quality per se?
I really don't know. It was an observation that I think we need to look more into. But it was more than what you expect by chance alone.
Can you show it again?
And actually, it was a fun thing when that turned into a flutter because, one of the great features of the system is how quick you can map the flutter, whether atypical or what have you. And many of them end up being showing exactly what Boris mentioned. You can get a mitral isthmus flutter with jamming of the isochron anteriorly, indicating an area of slow conduction. And many of them we terminated very effectively, very quickly by doing an anterior mitral isthmus line.
Yeah.
Can I ask you a question? Between PF and RF?
Before going back to your question, Debbie, can we show one time just the electrograms? Because we already noticed exactly what we have been discussing. And maybe, guys, can you show it? Can you see the electrograms? Of course, it's squeezed. But you see here, in the upper part with the lasso, we have two components. The far field, yes, thank you, and the spike. And then we did a couple of ablations and and with the next one, after this one, already the spike here from the spiral catheter was again eliminated. And this is, we may now go one time into the inferior vein. Here, inside of the inferior vein with the, you see this in the lower, now electrograms. Electrograms again. You see the position of the sphere in the left inferior vein region, and you see no spike. Also, this is at least changed, I would say, already at this point in time, which is, an interesting observation again.
Probably as an operator, I'm not supposed to ask questions, but since both of you in the panel are also very familiar with the system, do you find this useful? I mean, there is obviously pulmonary vein isolation without even touching the anterior part, the Coumadin ridge, with our ablation lesions. And so for the ongoing lesion deployment, we only have the 3D mapping information and we don't see the electrograms. So usually when you do RF, you orient your catheter also depending on the local electrograms, whether you're on the inside of the Coumadin ridge or on the outside, or what. Is it something that you're missing now, or is it not necessary?
Are you asking me?
I don't know, everybody.
Are you asking our panelists?
Let's start a conversation.
I'm going to jump in, and I actually do it similar to what Musa does. I do a single, it's a single transeptal, and try to do a first pass isolation, which is almost always almost always happens with this catheter. And then we're not routinely, it's almost an anatomical ablation for PVI, not really focusing on any of the EGMs, which I think is kind of how we are doing all of the PFA systems, taking a more anatomical approach. I think we're starting to see that we can't really depend just on EGMs to do. Musa or Atul, any other thoughts on Boris's question?
I'd just like to add one thing, Devi, to what you said. The sensor mechanism on this system is very good. So you can tell when you're in contact or not by the size of the white dot that Julian mentioned at the beginning of the procedure here. And another thing he also pointed to about the temperature rise, the small temperature rise that you see with PFA, which is another indication that you're in touch. So if you do those two things well, you really don't need to look at the electrograms, which, as you said, are irrelevant when you use PFA. Sorry, Atul, I interrupted you when you started to speak.
No, I was just saying that I think it's both. I think it is a problem because we are used to using electrograms as our endpoint. And it would be nice if we could find some surrogates of the bipolar electrogram to help guide our procedure. But I agree completely with Devi that it's turning into more of an anatomical based procedure for now anyway. I think there are going to be electrogram markers that we can look at in the future. But Julian and Boris, I wanted to ask you a question. You mentioned that you were doing this under deep sedation. So I assume that that's like a propofol infusion or something like that. From my viewpoint, I can't see any movement of the patient. Is that accurate?
Okay.
No, I'm sorry.
It's great. Maybe you may answer. I just move on with this, and
Okay.
then
Maybe the camera can focus on the patient a little more, show the belly of the patient while Julian is ablating. And yeah, that is the very valid point. So when we started using the system, we were using paralytics and GA. But after the reports that we received from Andreas Metzner's group in Hamburg, and we decided to go with deep sedation, and we tried it. I have to say that in most of the patients, there's only small movements of the patients, as you probably can see now. Very small muscle contractions that do not lead to a map shift and do not interfere with the procedure itself. We had some patients where we had more pronounced movements, but in all cases we were able to complete the case. So, I guess from the small number of cases that we've done, it's around 25. We feel confident to continue with deep sedation, but there may be instances where you need more than that.
Yeah, exactly. We had the initial 6 patients, Atul, in which we used GA, including paralytics. In the first 4, in the last 2 of the 6, we did not use paralytics. And of course, it was comfortable. But we observed, and this is obviously a certain issue I think it's all over the world, the lack or the shortage and the bottleneck of anesthetists. And therefore, we were very eager and ambitious to switch back to our daily standard of care, which is deep sedation, as we show here. In certain areas, we expect typically less movements, and in other areas, we typically observe a little more movements. And on the right side, for instance, anterior septal, we have typically more movements. I think it's also matching your experience, Boris, right?
Yeah.
So therefore, and
Julie,
also, of course, if patients, yeah?
Go ahead, finish your thought.
I was just saying, if the patient was very obese, of course, this may make it a little more difficult.
Why don't we just take a look at the poll results? Let's see how familiar our audience is with PF ablation. the first question for first poll was how familiar is everyone with PF? And it seems like we have an even mix. Very few that are extremely familiar, but as I think it's starting to build up momentum and people are starting to
How about here?
understand the system much more. Let's look at the second poll. And it looks like only 28% of our audience is currently using any kind of pulse field ablation in their practice. With that, let's open up the third poll. So the third poll was regarding what would change your decision. So what factors would influence your decision to recommend pulse field ablation over other established ablation techniques? Whether is it efficacy rates, safety profile, anatomy, cost effectiveness, or long-term outcomes data? We'll take a minute, take this poll results and come back to it. And back to you, Julian.
Oh yeah, thank you. So now we are moving along the roof, and maybe we may show us and share what we did before. And I believe there has been already some discussion around, PV angiograms. You can see here, this is a very, in an RAO, maybe the other one. You see this is an RAO, angulation 30 degrees, and it's in very, very anterior, uncommon course of this left upper pulmonary vein. And we have the posterior vein, which is pretty much in an posterior direction. So it's really a pretty interesting anatomy, I would say, just to let you know. And also the vein is pretty small. And of course, with regards to safety, and that was the point I wanted to make, we know, and this is something I think which is a good and important information, we know that the chance by the energy source per se creating PV stenosis is, I don't know if it's zero, but it's very, very low. And therefore, we feel pretty confident also ablating, let's say, smaller PV areas. And now we are here on the roof. PA?
So Julian, coming back to my first question about toggling between the pulse field and radiofrequency energy, I think that's a beauty of this catheter is that you have a little more flexibility in the type of ablation strategy you use or energy source. How do you decide where you want to use RF versus PF?
Yeah. Is RF still needed? That's a big question, of course. And what is the potential role for the for RF using, or what is the potential role of toggling in general? And I think most of us would agree that thermal ablation in areas which are potentially dangerous, like the posterior wall, we would prefer always PF over RF these days if we had such a technology available. However, and we discussed that as well, and I think you wanted to trigger this discussion about checking, let's say, linear lesion, bidirectional block, etc. Of course, if there was a large area of stenting, it would be more difficult. And this is maybe something in which RF may have at least an advantage, put it this way. What we did, but because of course we were super interested in the capability of RF ablation of this nice lattice-shaped catheter, we did typically our anterior lines with RF.
Another point that I would love to allude to is, of course, lesion quality. So we have learned now that when deploying PF with this technology, it's very difficult to interpret the electrograms. You basically they go away and you can't judge them anymore. But still, we're left behind with the question: is that lesion that we placed here, is it good? Is it transmural? Will it remain durable? Etc. etc. With PF, we have very little information on that because we're still learning about it a lot. And with this technology right here, we have at least one parameter that you always see in the map. In that lower graph, you see the orange line which indicates local temperature at the catheter. And depending on the temperature rise during the application, we, let's say, determine this lesion is good and this lesion is not so good, let's do another one. So that is at least one parameter that helps us to determine whether your local lesion is sufficient. As opposed to RF. With RF, we have used this for so many years, and we are a little more confident in saying, okay, this is a transmural lesion, this will be very likely durable when we see certain parameters change, such as impedance change, impedance drops, of course, with other catheters, with contact force information, et cetera, et cetera. So that might be one reason, in addition to what Julian already said, to use RF in certain locations to be more, let's say, confident in having durable lesions.
Okay.
I think at least in our practice during the clinical trial, we ended up using radiofrequency in the anterior aspects, especially the left side, to get, I guess, much more deeper lesions and such. So.
Yeah.
Julian and Boris, one question. You're now in the left superior pulmonary vein, and sometimes with certain technologies, I mean, you guys, for example, have done thousands of ferropulse cases. We'll sometimes see a vagal response near the left superior pulmonary vein, or maybe some coughing. Do you want to comment on that with this particular technology?
It's a very interesting aspect, and Atul, you really hit the point, because we have been exactly discussing this a couple of times in our lab before. With ferropulse, we typically deploy atropine because it is fairly common to see a strong vagal response, whereas according at least to our observation, this is not to this degree the case with the Ferra technology. So therefore, I can only speculate. I don't know if you guys share this observation, and maybe it is related to the, let's say, the recipe of the PFA waveform organization, or this is something at least we don't observe it that often.
Yeah, I don't know exactly what the reasons are. I think as Boris said, we're still learning about this. And what I'm about to say is just pure speculation. But it may just have to do with the size of the field. I mean, the single shot catheters are much larger. They're producing a much larger field, and therefore you may stimulate more of those vagal responses than a kind of, if you will, a point-by-point catheter where the field is a little bit more constrained.
Yeah. So now, I don't know. We still have some time. That's good. I was just wondering how much time we do have left. What we do
Julian,
now?
can we look at the results of our third poll?
Yeah, please.
I think you've shown the beauty of this technology with how easily you're navigating this catheter and sitting down and doing this procedure very comfortably. So let's look at the third poll. We were asking the audience what factors would influence their decision to recommend pulse field ablation. So let's take a look. So it seems safety is what carries the weight, as it should, but trailing behind very quickly is efficacy rates. I see that there's not as much influence with anatomy, and cost, I think, is still going to be something I think we will have to discuss in the future. But definitely the safety profile of pulse field technology seems to carry its weight alongside. So back to you, Julian. This was your question. How is the adoption of pulse field being in Europe?
Yeah, that's a good. Yeah, I mean, as far as understood, the main driver would be safety, right? This is what I was hearing. Please excuse, I have got two mics on my head, and there's also some communication from outside. For you guys, we did an angiogram of the left atrial appendage. Okay, the spiral catheter is sitting in the left atrial appendage, and we have 100 plus activation time to LA. The P wave starts a little more early, I believe, you guys. Yeah. And therefore, we will go and keep in mind, we already also observed these. Yeah, perfect. Here, it's pretty nice. We would go for RF lesion in this position. Go a little more down again. So we have a far field from the ventricle. Now we have a pretty good ratio. Then we switch back. Okay, now we are in this temperature-controlled RF mode. Here we go. And we would start our first ablation.
So while Julian is doing this, Atul, may I ask you, I mean, you're the master of persistent AF ablation with different strategies. I'm talking about STAR-AF too. Would you think that with such a technology, you need to repeat the trial and see that maybe linear lesions do have a benefit, or do you think it's not worthwhile doing so?
Yeah, I think that's a great question. I think that it all comes down to how durable we think these lesions are. And I think with this particular technology, especially with the RF aspect, you're getting pretty good tissue depth and probably very good durability of the lesions that you're creating. Like, I think trying to create this line that you're doing right now with a point-by-point RF catheter would be very, very challenging to do. And so I think you're absolutely right. The value of these sorts of linear lesions may be completely different now that you have the opportunity to create, a solid, durable, linear ablation.
Wow. And Atul, while you have been commenting on this, now we induced a FIP.
Atrial No, AFib.
AFibs, yes, it's the AFib. But I did jump over and mechanically probably induced here. So that's my tilting point. I keep my catheter here, but maybe we go back to the electrograms and the review mode, because while we ablated RF, we exactly observed what we typically observe. Exactly. And here you see we had the baseline time to LAA in sinus rhythm. And now with the, I think the almost the last or one before, we had jumping on a massive delay. You can see it's already almost in the beginning of the QRS or in the QRS complex right here. And therefore, this is already did indicate that at least the lesions before we did have at least some biological effect on our line, on the tissue here.
It's plus 80 milliseconds now, the conduction time to the left atrial appendage. And that certainly, dissected some of the Beckmann's bundle already. So of course, we need to check for bidirectional block, but it looks quite promising already.
What we do now, we do switch back from RF to PF. Okay, now you may ask why. And it was following at least official recommendation at this point in time, because the phrenic nerve may be in some, let's say, distance, and therefore, in order to be super, super safe, we now go back to PFA here, and we do this one in PF.
Maybe you can show the still screen of the ECG one more time. I don't know if you've seen it. I'm in review mode, EKG nochmal. Yeah, here Stefano pulled it up. You see baseline 106 or something, and then the next beat during the RF application at 80 milliseconds longer. And
can I open up a debate
that is impressive.
I hope you guys can see it.
Okay.
Yes, we
Go
can.
back to the map.
Richard, you had a comment?
we can see it.
Yeah, so
Are you
I
ever worried
Okay, wonderful. I do one final one up here.
but Julian, I just wanted to
Okay, good.
raise a debate or a question.
Right?
As Spider-Man said, with great voice, I think it was his uncle said, with great power comes great responsibility. And with these types of technologies, we now have the ability to ablate a lot of atria very, very quickly. And the question really is, if we're doing this without really understanding what we're doing, are we reducing left atrial transport and negating the benefit of sinus rhythm without really getting a trade-off benefit? What's everyone's view on that?
Yeah, Richard, I think you're absolutely right. I mean, we need to be very responsible with the new devices that we have in our hands, and we also have learned now that with increasing number of applications using PF, we can get side effects. One side effect being hemolysis, and then as a consequence, acute kidney failure. So this is something that we need to keep in mind, and of course, the atrial transport function that you brought up is also extremely important. So I think we not only entered a new area in terms of pulmonary vein isolation, durability, but we also need to rethink our ablation strategies for various types of atrial fibrillation, because the lesion sets that we're deploying are obviously much more durable than those that we had before.
Boris, there's a question from the audience. They want to know if you have any experience in using this catheter for left atrial appendage isolation. And to add to that question, are you concerned when you do the anterior mitral lesion with this catheter in isolating the appendage unintentionally?
Yeah, to the first question, we have not yet tried to isolate the left atrial appendage with this catheter, and we haven't seen any LA or inadvertent LA isolations while drawing the anterior mitral line. Usually it takes more than just that anterior mitral line. You also need to block the posterior entrance to the left atrial appendage, namely the posterior left atrial isthmus. And yes, we have some experience with the posterior left atrial isthmus, and we also can block it quite easily, but we haven't combined the lesions yet in index ablation procedures.
Okay, so why don't we cardiovert one time? Now, we did something what we sometimes do in persistent AFib patients. This patient, of course, is as Boris indicated before, pretty severe and symptomatic persistent AFib, multiple cardioversions and failures later on. And therefore, we did PVI. So let's summarize. We did, based on substrate information and based on time to LA activation, our anterior line, and we also did a roof line. And for the all lines, except of the anterior aspect of the anterior line, we used PF as the energy source. And now, of course, we see still in the electrograms, maybe you see show us the electrograms one more time, please. Switch back to ECG. Wonderful. We still have a very long delay. You see, still exactly after this jump of 80 milliseconds plus. But of course, we need to check if this is still blocked. And the same is true for the roof line. And therefore, I suggest that we try to use a nice feature from the tool, from the mapping tool, looking at the the arrow. Can I see AP and right lateral, please? And maybe. Okay, and now we do the following. First of all, I get my catheter into a proper position, and we put it maybe down here. So we go for some atrial signals, of course, and then the question comes up, and here we have some atrial signals. And now you see there's this blue arrow. And you see activation from the blue arrow is running from down to up. And now let's pace, guys, from the appendage. Yeah, let's pace. Yeah. Wir haben noch kein Capture. No, not yet. Not yet. Let's go for a capture from the spiral. Here. Now we got capture.
Yeah, now we
you see, you see, first of all, the activation on our sphere 9 is super late. Again, super late. And I would like to see the arrow, guys. And you see the arrow is pointing from down to up. At least it appears to be. Okay, we do pull a little. Yeah, here you see it from down to up, indicating that the activation is now coming from inferior and then goes up. As in, let's say, sign of bidirectional block, apart from looking into our electrical information. And here, again, I would like to point out for the second, or for the small component, which is very, very late in the sphere 9 catheter before the far field V. Okay. We map a little bit around in the meantime to also, of course, collect a couple of more mapping, or most of you may be very familiar with high density, nice colors. And of course, we want to create all those colors as well. We still, and I have to admit, like to look into our local electrograms, and we still like it. Maybe we are getting the dinosaurs. It's going to be very fast, getting a dinosaur. But still, okay. Now we go above our line. Above the line, above the line. And you see the nice arrow direction indicating the activation, which is measured and analyzed across the sphere 9 catheter. And maybe I dive. The lasso is dislodged. Okay. Yeah, no, I'm sorry. It's my fault. I took off the lasso. Okay. I'm sorry. I'm sorry, guys. Okay, here. Wow. All right. Okay, but I think you can already appreciate that.
It's not capturing, right?
Push it. Did I lose it again? No. Still in?
Oh, now we got capture. Yeah.
Hardly any signal.
Just while you're analyzing this, Boris and Julian, are you concerned at all? I mean, obviously you're not isolating the left atrial appendage, but if you have a long delay of activation into the left atrial appendage, are you at all concerned about the potential prothrombotic risk there?
Well, we have not analyzed this in detail in our, let's say, institution, but I would speculate that despite the fact that it is activated very late in atrial systole, it is still activated, and it still remains its mechanical function, and the emptying velocity in the LA probably is preserved. Of course, as I think Nasir also showed, is that with more pronounced atrial substrate,
Hier, der blaue Vektor ist so schön, oder?
You also have a more prothrombotic state in the left atrium, and this might also be one factor to consider when you contemplate to stop or to continue anticoagulation.
Just let me again point towards this nice feature with the blue arrow, now pointing from down to up. Again, also indicating that our roof line is blocked and the full activation is running from inferior, running up cranial, and then as a result, you see the resulting vector, which is depicted in blue here. I'm sorry, did not want to interrupt your answer, just because I was here. Yeah.
I think it's important to do that roof line when you do an anteroseptal line, because you need to block the septopulmonary bundle to avoid colliding wavefronts in the future. So these colliding wavefronts, if you did not do that line, would probably lead to more repolarization abnormalities and maybe atrial fibrillation.
Richard and Atul, I want to take a moment to thank you guys for kind of sticking around with us and being part of this great case. I do want to give the final word to Boris and Julian, but any final thoughts from Richard and Atul first? Richard, I'll start with you.
Yeah, so I wanted to wonder or speculate how important the appendage is to atrial transport. It's the only closed-ended pump in the atria, and I think we sometimes underestimate how much it contributes to the kick of the atria into the ventricle, but I've not been able to find any evidence that that's the case. So I would agree with Julian and Boris that isolating the appendage is something that one wants to avoid if one can, not just for thrombotic risk, but also potentially for the symptomatic benefit of being back in sinus rhythm. And Atul's completely changed the way that I did persistent AF ablation. I moved from substrate ablation and linear ablation to PVI. And for the last few years, I've been getting really good results. And I reserve doing something more extensive to patients who have recurrence after PVI. And I think that the number of patients I'm doing that on has dropped dramatically because quite a few just get a good outcome from a PVI.
Yeah, I would have to second that. I mean, I also moved from fairly extensive ablations to much more restricted ablations after the results of STAR-AF2, and I don't know whether it's contact force or improvements in RF, but the results more recently have really been much better, and I'm looking forward actually very much to being able to use this particular technology. Boris and Julian, I'm very jealous that you guys get to use this stuff clinically so much more in advance than we do, and you've certainly made it look very easy. And maybe in your final comments, you have the ability now to use more than one PFA technology. When are you going to use this one, and when are you going to use the other one?
That's a very, very good question, Atul. And I think with 99.9% of all of what you guys said, I would personally agree. I think Boris also. The very challenging question, of course, is in what scenario we would bring up, let's say, a single-shot device, maybe PFA, or such a more versatile and sophisticated device. I think the verdict is still out, especially in persistent AFib, but because I believe that with one of the problem for all studies was that the low durability of all our lesions, and this is something we need to recook maybe in a certain way. But of course, a single shot PVI isolation procedure is very, very fast and can be very fast and also very efficient. Still, the beauty of the technology, in my perspective, lies into the true versatility, substrate-based ablation, smart lines, etc. But of course, we need to study more, and I think we will learn very much in the future, maybe from STAR-AF3 as well.
I have no doubt you guys are making the technology look good.
They're masterful operators. Well, thank you so much. We're nearing the end of the session, and I really want to thank Boris and Julian for a great case and how wonderfully they demonstrated the technology and how they made it look so easy. And our thanks to our panel, Richard and Atul and Musa, who will be staying with us for our next session. See you there in a few moments.